So we'll talk about agents first. So there's kind of three major classes: particle embolics, liquids, and coils or plugs. Okay, so the goal for all of these is to block flow or block the channel, and the application of each one of these classes will depend on what you're trying to achieve. So we'll start with gel foam, which is the most basic, one of the most basic and most one of the oldest embolic agents that we have. It's technically a particle embolic. It's made out of purified subcutaneous adipose tissue from pigs. It comes in these little packets. You may have seen these little packets, little rectangles. That's called a sponge, or it comes in a powder as well that you can mix with contrast and saline to make a slurry. So we use this all the time, and when we do biopsies, we particularly in the liver and the kidney, where we worry about bleeding, we put a little bit of the gel foam on our way out, and the way that we use that is called a torpedo. So we take a little piece of the gel foam, we roll it into a little a cylinder. We put it on the tip of a small needle, a small syringe, and then we inject it into the biopsy needle that we have, and then we push it out. And what that does is that gel foam fills the hole that we made with the biopsy, and it causes clot to form. And it's easily seen under ultrasound and CT because it has air in it, and that air kind of stays in there for several hours until it gets reabsorbed. Gel foam is also used in a slurry form, and this is really something that's very commonly used in a lot of our procedures. It's a very flexible embolic, so we can put a big chunk of it in, and you can sometimes you can even inject these torpedoes through a catheter if the catheter is big enough, and you have a 1 cc syringe. You can inject these torpedoes in, but a lot of times when we're using this through a catheter, we're going to use it as a slurry. And all you do with the slurry is you chop up the gel foam, you put it in a syringe, and then you mix it with saline and contrast at a rate that's at a ratio that gives you a viscosity that you want. So if you want really thick gel foam, you put mostly contrast, and you would not really mix it too much. You would leave the gel foam kind of partially mixed. And this three-way stopcock, you'll see us doing this. We push the gel foam in and out through the syringes to kind of emulsify it and mix it with the contrast. And if you want it to be more viscous, you do that less. And if you want it to be really viscous and to penetrate more distally, you do it more, and you put a little bit more saline in it to make it less viscous. So the nice thing about gel foam is that it's considered a temporary embolic. It's supposed to be resorbed by the body within about 2 weeks. The pluses and minuses for that are the following. So if you have a temporary embolic, obviously the risk that you run is that you're going to have recurrence of the bleeding that you wanted to avoid. But on the plus side, it means that there's going to be less long-term ischemia potentially to the organ that or vascular bed that you're putting that in. So, and that doesn't apply to everything. So, for example, if you put a bunch of gel foam into a renal artery, 2 weeks of ischemia is a very long time for a kidney, who can only take about 6 to 12 hours of ischemia. So that could kill the kidney. Okay, the channels will recanalize, but your end organ would be toast. Now, if you have a trauma, for example, and you saw a active bleed on CTA, the patient was unstable, and it was like in the gluteus muscle. Okay, like that's a common site for people to have bleeding. It's gluteal hematoma. active extraval on CT, but then you bring them into the room, you do your angiogram, and then you don't see it anymore. If the patient is unstable or there's another reason to do a prophylactic embolization, gel foam is a great choice because you can stop the blood flow to that area for a couple weeks, and then over time it will recanalize and still allow perfusion of the area, and you are potentially reducing the complications related to ischemia when you do embolize it. So we use it very often in trauma, and it's also a really useful adjunct when we have to put in coils. I'll talk more about that in a minute. So after gel foam came into the scene, they developed this stuff called polyvinyl alcohol, and this thing is really it's literally a plastic. The molecular structure of it's over there is really simple, and it's made into these tiny little fragments, and those fragments are, when they manufacture this stuff, they put it through a sieve, and that filters out the sizes of the embolics that they have, and you see there's a range in all these little bottles, and so you'll hear us say stuff like, oh, I need PVA 250 to 350. So the text will give us this, and that's the size range in microns for the particles that we want. And some procedures like bronchial artery embolization, for example, have a particular size of the particles that we don't want to go below to avoid complications. The PVA will look like a snow globe. It will look like, you know, when you take a snow globe and you tilt it and stuff is all floating around. That's exactly what it looks like when you mix it with saline in contrast. And the advantages are multiple. It's cheap. It's widely available. It does cause inflammation when when you administer it. The other disadvantage of it is that it's clumpy. So when you take these particles, you can imagine they're not regular, and they may clump, and the small particles may turn into bigger particles when you're administering them. So they can clog, similar to gel foam. They can clog catheters, and they can clump and give a little bit less predictable level of embolization than what you want. The next generation of embolics that came in the 80s and 90s were spherical embolics, and spherical embolics have a bewildering variety of types and applications and uses and so forth. So these particles range in size from about 30 microns to 1400 microns, which is about 1.4 millimeters. The use of these depends heavily on the application. So there's bland embolics, drug-eluting. There's radioactive embolics that we use for Y90. SIR spheres, for example, these are resin spheres that are coated with the isotope of yttrium called yttrium-90 that we use for Y90 radioembolization for treatment of liver tumors. You can see the spheres are very, very uniform in size. Another type of this is quadrispheres. That's another type of sphere that's used in chemoembolization. These spheres, for quadrispheres, for example, they swell up. So when they get mixed in a solution, they get bigger, and they also give you a range of sizes. DC beads, that's the one in the bottom. That's one that also has a range of sizes that you mix with some kind of chemotherapeutic agent for delivery into tumors. And then at the bottom right over there, that's embosine, and embosine is a bland embolic. It's calibrated in size, meaning that there's no size range, and the size that you get is the size of all the beads that's in that vial. So one of the things that's important to remember and with spheres is the compressibility of these beads. So when you inject them, Some beads are stiffer than others. Some of them have the ability to kind of squeeze into more of an oval shape and go in a little bit further and penetrate a little bit further into the area that you're embolizing. And some of them don't. For example, the resin spheres for Certec, they're not very conformable. Glass spheres for TheraSpheres, they're not conformable because they're made out of glass. But they're tiny, they're like 30 microns. And spheres like Embozine, they're not really that conformable, and they're calibrated to be a certain size. So you know that when you take 100 micron Embozine, you know that you're embolizing vessels down to the level of the 100 micron vessels. Okay. If you take embospheres, for example, that's or quadrispheres, those are as a different material, and you'll know that those are more conformable, and they may penetrate a little bit further in than what you would expect. And they've done all sorts of studies showing, you know, in animal studies showing the penetration of these beads, showing that, you know, these conform to a vessel, and they kind of squeeze through a little bit more than others. So the next big group of agents that we use are coils. So they come into big category: pushable versus detachable, and 035 versus microcoils. So you'll hear us asking for a type of coil. We had to specify how they're delivered. So are they pushable or are they detachable? And how big are they? Are they going to be? So when we're doing a trauma, for example, and we need to block off a gluteal artery, that's a big artery. Our goal is to stop a bleed in a gluteal hematoma. That's actively extravasating. We can quickly put in pushable coils. Those are going to be 0.035 coils, and that number relates to the caliber of the wire of the coil. Okay, so you've seen us. You guys probably all handle wires and micro wires and catheters. So the standard width for a guide wire in IR is 0.35. Okay, or 0.035, 0.03 of an inch. That's the standard size of the wires that we use, and also the first coils that were made were 035 coils. And the goal of the coil is for it to basically just pack the space. So the coil is very similar in look to a wire, a guide wire, but it's much more shapeable in the sense that it's very floppy. So when you push it out of the catheter, it's going to immediately start forming. And eventually in the 90s, they came out with microcoils. So you could go even further distally, open up more applications for embolization. And microcoils are typically 0.18 in caliber. So they're about roughly half the size of the in diameter of the 035 coils, and they can be used via microcatheters. The pushable coils, you don't have control over them after they deploy. So if you misdeploy a pushable coil and it embolized or it unraveled after your deployment, you're done. That coil is there. So you can't take them out with snares, but if you use a detachable coil, you can pull it back into the catheter. And there's a couple different systems for removing, for deploying the coil. One of them is mechanical. There's an example here of a mechanical coil that you pull back the back of the coil, and it unsnaps this little hook at the back of the coil and leaves the coil in place. And you have much more control with detachable coils. You also have detachable 035 coils nowadays as well, give you a lot of control of being able to do these. So coils are used in a ton of different applications. They the thing I want you to remember about how coils are used is that when we want to block a big vessel, okay, when we want to block a large vessel, coils are usually the way to go. And they'll have different mechanisms of action in terms of how they cause hemostasis. Some of them are called hydrogels. Hydrogels are coils that have a bioactive coating to them that when they go into the bloodstream, they start to puff up and they take up more space than they did. So, which is really handy because it keeps the profile of delivery really low, and they take more space than they did in the body versus in the catheter. Most coils have little fibers attached to them. These are little nylon or other material, cotton fibers that are very thrombogenic. This is an example on the top left is an example of a tornado coil. That's a very standard 035 pushable coil that we use in embolization. It has these little hairs, and they're very thrombogenic, so they cause platelet aggregation on the coil and thrombosis of the vessel that we're doing. The next agent, yeah, go ahead.
Quick question for you. Mm-hmm. On the coils, what would be like a situation where you would rather use a pushable versus a detachable, since you don't have like the control that you mentioned?
Yeah, so for big vessels, a situation, for example, would be when you're doing a ovarian vein embolization, and you're on your way out, and you need to put in a ton of coils, and you want to be cost effective. Pushable coils are fine because if you're in a longish vessel, and you're not really worried about if the coil is not going to if there's very little opportunity for that coil to embolize, and you're just embolizing a long straight vessel, that's fine. You can use a pushable. It's pretty safe to do that. Now, when you get to a branch point, like if you're in the gastroduodenal artery, for example, and you're embolizing the distal gastroduodenal artery, you can start with pushable coils. Then, as you get close to the origin of the gastroduodenal artery, close to the proper hepatic artery, you don't want the coil to herniate into the hepatic artery. So you may start with pushables and then switch to a detachable coil as you finish off the GDA embolization. Does that make sense?
Yeah, that makes sense.
So you have to read the situation and say, okay, well, here in this vessel, I'm distal. There's very little opportunity for this coil to embolize somewhere else. There's really nowhere else for it to go. I can use a pushable here. And pushable coils, you can actually shoot them out of the catheter if you take a 1 cc syringe. You can push them really hard with your hand, and they go really fast and almost instantaneously form. You have to be careful using that technique. I only use that if I'm trying to go really fast in a place that's safe, because it can kick your catheter out and you can lose access to the vessel that you're trying to embolize. And you can't do that with detachable coils, of course, but it's a very case by case and situation dependent.
Okay.
All right. So plugs, this the other. They're coil-like in that they take up space. They're very similar to coils in application. Virtually all plugs are detachable. They're very controllable, and they're really effective at blocking flow. So the first one over here on the top left is a MVP. That's a microvascular plug. It's a PTFE covered mini stent that's kind of tied up at both ends. And the way that this thing works is just when you push it out of the catheter, it opens and it just blocks flow. It acts like kind of a inverted windsock, and it's just blocking flow. It's pretty handy for large vessel embolization like pulmonary arteriovenous malformations, splenic arteries, things are relatively large. They have they call it microvascular plug because this is a very low profile device. You can fit it through they come in some sizes that you can fit through a microcatheter. So in choosing, there's no right answer when you want to do an embolization of a large vessel or a largish vessel, and you're thinking, should we use one microvascular plug or multiple coils? It depends. So it depends on how predictable you want your blockage to be. So and it depends a little bit also on how easy is it to get a catheter to where you're trying to go, and how much room do you have? So the coils can be really long. So for example, like a micro coil can be up to 60 cms in length. That's like, for example, a Ruby coil. Those coils, they're really, really long, 60 cms. You have a lot of room to pack that coil. You need a lot of room to pack that coil. So that wouldn't be appropriate in a really short segment of a vessel that you're trying to embolize, where a plug may be more effective and safer. Okay, so you also have to look at the anatomy that you're treating when you decide. This plug here on the top right, that's a Embolics 4 plug. The is a very handy device. It goes up to 8 millimeters in diameter. You can deploy it through a 4 French catheter, so a 4 French 035 catheter. It looks like two Hershey's Kisses kind of on top of each other. And they work really fast. They're really useful for splenic artery embolizations. For example, you can usually just put one in there for proximal embolization, and one of them is usually enough to shut off the vessel proximally. The other one down here at the bottom, that's an Embolics 2. It has these discs on it, and this mesh that they're made out of is a nitinol mesh, and they're very thrombogenic. So it activates platelets like crazy when they flow through this, and they work really fast usually. One of the downsides of the MVP is that when you deploy this thing, it's like you're throwing a blanket against the wind. That blanket is going to get carried by the wind. So when you put it in a vessel, if you didn't size it appropriately, if you didn't oversize the microvascular plug enough, it's going to have a risk of embolizing. It's also really smooth, and it travels easily inside a vessel. And that's not the case with the Embolics plugs. When they first come out, they allow flow through it, so they're a little bit less likely to embolize. And then finally, the liquid Embolics, which is the most unpredictable class of Embolics. It's really tricky to use. Takes a lot of practice to use these guys. The glue is one of the first liquid Embolics that we were using. And glue is you're basically using super glue. It's cyanoacrylate glue, and it's just medical grade and really expensive. The glue is mixed. It comes usually in about 1 gram little aliquots, and it's mixed with this stuff called Lepiodol. I don't know if you guys seen Lepiodol used in the IR rotations, but what Lepiodol is, it's a derivative of poppy seed oil. It's about 70% iodine by weight, so it's really radiopaque. You can see it really easily under X-ray. It's a type of contrast, really, but it's used in embolization all the time, particularly with glue. So the thing with glue that you have to be really careful with is that if it comes in contact with any ionic solution like blood, it'll instantly polymerize. And to handle it, you have to have really clean gloves, and you have to use D5, glucose 5%, to flush your catheter and flush syringes that you're using. It. Otherwise, the glue is going to precipitate in your hands, going to precipitate and polymerize inside the catheter, or you could even the most devastating complication you can get with glue other than serious non-target embolization, is to get a catheter stuck in a patient because the glue glued the tip of the catheter to the vessel. Okay, that can happen, and it's a tricky thing to solve as well if you have it happen to you. So when you take glue and you're putting it and you're preparing it, so you have to kind of try to figure out how distal do you want the glue to travel. So if you have to embolize proximally, you want that glue to precipitate or polymerize more quickly, so you mix it with less Lipiodol. If you want the glue to penetrate further into the tissue, like if you're in a lumbar artery, for example, and there's a retroperitoneal hematoma, and the vessel that it's coming off of is tiny, and you can't get a microcatheter into it, you can use glue in that situation to try to push the glue all the way out to that tiny vessel. So in that case, you would mix it with more Lipiodol. So the more Lipiodol you mix it with, the longer it takes for the glue to polymerize. And usually we do 1:1 to up to 1:5 ratios, depends on what you're trying to do. So if you really want the glue to take a while to polymerize and you want it to travel more distally, you mix it with a little bit more Lipiodol. Usually when you use glue and you flush your catheter, your catheter is kind of toast, so because it may get blocked. So when you apply glue, usually that you have to have the expectation that that catheter is going to have to be removed, and you're going to lose access to the area that you're treating. So you really need to be sure that where you're putting the glue is the only application that you need, because you may not be able to get back into that vessel. Onyx is another type of liquid embolic. It's the stuff that expands when you push it out of the catheter. It's not like glue at all because it's not sticky. So what Onyx does is just it takes up space, and it doesn't really polymerize like glue does. It starts to harden over time when you push it out of the catheter, and it inflates kind of like a balloon. So here in that little vial that they're showing there, they're pushing Onyx out, and what's happening is that the outside of this thing is getting hard, but the inside is still really soft, and the whole thing kind of expands. And it's really used a lot in neurovascular embolization for aneurysms, for example, because it's not going to get your catheter stuck to a vessel in the brain, and it's relatively predictable when you're deploying it. It will not get the catheter stuck to the structure that you're embolizing. The downside with Onyx is that it's super expensive. It's like $7,000 for like a vial of this stuff, and it takes a while to prepare it. So if you know you're going to use it, you have to start shaking it, because it settles in the vial, and you have to start shaking for at least 20 minutes. It also, you mix it with this stuff called DMSO, and it's the solvent that it's mixed in. And if you use a large amount of it, sometimes back in Virginia we used to treat Embolics with this stuff, and sometimes we use a lot of it, and the patients would smell like garlic for days, because when the DMSO stuff is metabolized, it makes you smell like garlic for some reason. We don't really know why, but sometimes you walk in a room of a patient that had been treated with Onyx, and you smell like it would have this raging smell of garlic. It's kind of funny. Other liquid embolics that we use, absolute alcohol. You can usually use that in mixture with Lipiodol to make it more viscous. Absolute ethanol is super toxic to the endothelium. Will kill everything it comes in contact with. We use ethanol for embolization of angiomyolipomas in the kidney, for example. We mix it with Lipiodol because you're trying to kill that. It's a benign tumor, but you want to kill it because they can bleed. So, and you really need to penetrate far into those small vessels. So you mix it with Lipiodol in different ratios. There's sclerosants as well, so Sotradecol, Polidocanol, for example. These are detergents. Sotradecol is a type of detergent, and usually you mix it with air and plus or minus Lipiodol, and when you mix it with air, it turns into this foam. And the nice thing about the foam is that it expands inside the vessel, and it allows the detergent to come in contact with the endothelium of the vessel that you're in, that will destroy that vessel and cause it thrombose. So embolic therapy in 2021. So what do we use it for? I mean, the list is huge, and each one of these dots on the list has its own sub menu of other indications and types of procedures that we do. So just GI bleeding, you know, there's upper GI bleeding, lower GI bleeding. With trauma, that's an immense area. You know, it can be peripheral trauma, it can be visceral, solid organ, et cetera, et cetera, et cetera. So we don't have time, unfortunately, to cover all of these, but I wanted to show you guys a few cases. So for trauma, for example, some of the more common organs that are injured in blunt trauma will be the kidneys, spleen, retroperitoneal hematoma, and we do a fair amount of iatrogenic injury as well. So when we biopsy a kidney, we're always putting that patient at risk for a renal hemorrhage. That would be an iatrogenic injury that we may have to embolize. This is an example of a kidney that was injured in an MVC, has a pseudoaneurysm kind of at the hilum over there. This is another example of iatrogenic trauma to a kidney. What you're seeing here is a renal angiogram, but there's this tail going away from the kidney down in the lower pole, and that's a active extravasation in the track of a nephrostomy tube. So this is a patient that probably had the nephrostomy tube placed a few weeks ago. There's this really well-organized track. Okay, so when you put a tube in somebody, the body will seal off that track with fibrin, and that's what we call a organized track or a well-developed track. And this person was probably having hematuria. And when we were doing the angiogram, we pulled the tube out and found out that there was this leakage of contrast out into the track. And that was treated with a single microcoil. So you see that track no longer filling with contrast in the angiogram afterwards. And the thing to keep in mind here is that you are cutting off blood supply to whatever that vessel is distributing. So you have to keep in mind how much of this kidney you're taking out when you have to address this. Here's an example, a case I did back in Virginia. This is like an 18-year-old kid that was driving drunk and got into a horrible car wreck. They took him for an exploratory laparotomy. Luckily, they took him to the hybrid room, and they called me in the middle of the night to come see if they could find a bleed, because they didn't get any CT scans on him, nothing. So all they had was an open belly. And I got there, and then I just kind of started doing angiograms, and eventually we luckily found this lumbar artery that was extravasating, and we're able to pack it with coils and get it to stop the bleed. Checked the levels above and below, found a couple other bleeds, and we're able to stop it. So that, you know, if the surgeons had cut into the retroperitoneal hematoma that he was developing, it could have been a mess, because you decompress it and you just make it more likely to bleed. So luckily he was in a hybrid room when we had access to fluoro to do this. Splenic trauma, also super common. There's this grading systems for splenic lacerations, but the important thing to keep in mind is what the status of the patient is. So, and it varies a little bit in institutions as well. So here, if the patient is unstable and they have a splenic lac, most of the time the surgeons will take them to the OR to get a splenectomy. If they're stable and they have a splenic laceration and they have drop in hemoglobin, or they start having a lot of pain, or they're stable but kind of teetering on the edge of not being stable, they may call us to do a splenic embolization, splenic artery embolization. Most of the time, we're not going to see active extravasation on these. So what we do in those situations, we just put a proximal, do a proximal embolization of the splenic artery. Here, we just deployed a plug over here and cut off the majority of the blood supply to the spleen. The spleen is still going to get perfused via short gastric arteries and pancreatic arteries. So you kind of want to go distal to the pancreatic arteries when you're doing these embolizations to maintain perfusion to the spleen. Most people, you don't need to get vaccinated when you do a proximal splenic artery embo. Most of the time, it's enough. You have enough splenic function that you don't need it. So upper GI bleed. Here's a case of. Can you guys tell me what the finding, the pertinent finding is here? This is a gastroduodenal artery angiogram. I have a microcatheter going into the common hepatic artery and then into the GDA here. Can you guys tell me what the pertinent finding is there? Anybody want to take a stab at it? There's a little aneurysm. Yeah, exactly. There's a pseudoaneurysm hanging off the side of the GDA here that was in an ulcer. Okay, there's a little bit of vasospasm in the vessel there, but there's this pseudo, and this guy was bleeding from the pseudoaneurysm. They saw it on endoscopy. They tried to staple it. Nothing could attach really to it. Luckily for me, he stopped. Okay, he stopped bleeding. The pseudo partially thrombosed, and then when I went in there to treat it, I was embolizing the GDA. I started distal, and then one of my coils popped through the aneurysm, and then you start seeing contrast going into the duodenum. Okay, so when you can change that, you know, these are very fragile plug that you have over here, and I don't try to retrieve the coil here. You just want to finish off coiling the GDA. Okay, you just need to move because now the guy's bleeding. So did the whole embolization. There's the coil hanging in the duodenum over there. Okay, and he'll pass that. He'll come out the other end. It's not a big deal. But here, this is a great example of the you can start with pushable coils, and then as you get to the top, where you're getting close to the hepatic artery, you can switch to detachable coils, so you have more control of where you're putting the proximal coils. I had a case of GI bleed, on upper GI bleed like this, a GDA embo, on a transplant patient. I had a detachable coil, but I was able to pack it all the way to the proximal GDA, and then the next time I stepped on fluoro, the coil was unraveled in the transplant hepatic artery, and there was zero flow in it. So even though you have good control of these coils, sometimes the patient will throw you curveballs. So we had to retrieve that coil because you can't leave a coil in somebody's transplant hepatic artery. So even though you have really good control, sometimes things happen that you don't anticipate. This is a really interesting case. It's like a 55-year-old prisoner that was having these intermittent bouts of severe hematochezia. And what you're seeing here, this is a mesenteric artery angiogram. And the mesenteric artery is this big vessel. The black arrows are pointing to some anastomotic connections between the celiac artery. This is the splenic artery going to the top left here. And there's this other pancreaticoduodenal arcade connecting the celiac artery to the SMA here via the pancreaticoduodenal arcades. And they have aneurysms all over the place. And she had this big aneurysm, pseudoaneurysm in a mesenteric branch, and that open arrow is pointing to this nipple in the pseudoaneurysm that was actually fistulizing with the duodenum. And she was getting intermittent rupture of the pseudo into her duodenum. It was intermittently thrombosing, causing these severe bouts of hematochezia. And we put her on a CT scan, and she came in to the hospital. They were scanning her, and then suddenly she coded. She just started bleeding a ton. And then we immediately put her on the angio table. She stopped bleeding for the time being, and then I started treating it. And then when I was packing this aneurysm with coils, you saw this. So it's kind of hard to see here. Let me see if I can stop it. There. So that nipple ruptured, and now you're seeing contrast just pouring into the small bowel. So we had to move fast and finish embolizing that pseudo. She came back a couple months later. I followed her up with a CT, and the coil pack unraveled and to the duodenum. So we got hemostatic thrombosis, the pseudoaneurysm, but the coil pack unraveled and turned into a coil beater. So it was a pretty interesting. We actually published this case where we saw the coil in the small bowel, and the endoscopically went in there, and we were able to pluck these coils out, and she didn't rebleed, fortunately, but you can see there that they cut the coils off there and retrieved them. But that was probably about $100,000 worth of coils in this aneurysm that went into her gut. I mean, it was an interesting case, and she did okay. She actually, the diagnosis here is segmental arterial medial lysis. It's this condition where people just get aneurysms in the visceral arteries. And one of the things that was predisposing her to having these visceral aneurysms was that she had celiac artery compression by the median arcuate ligament. So these vessels are trying to hypertrophy, and in hypertrophying, they became aneurysmal because of the SAM. That was an interesting case. So upper GI bleed. So much time do I have? Oh man, I only have like 15 minutes. Upper GI bleed. So another etiology of upper GI bleed is venous or variceal GI bleeds, and we see that very frequently. We're a big liver center, so we see a lot of cirrhotics. This is a case that's called a BRTO. It's a balloon retrograde transvenous obliteration of gastric varices. This is the stomach here. You see these light gray, those are the varices. And what we're doing in the BRTO is we're obliterating the varices with sclerosant. And then we put the balloon in there so the flow doesn't, the sclerosant doesn't reflux into the renal vein and go to the lungs. The TIPS is another major procedure that we do that uses that technique as an application for embolization. So uterine artery embolization, now it's a accepted alternative for treatment of fibroids. We use particle embolics in this case. So if you just put a coil into the uterine artery, that embolization is too proximal, and what's going to happen is the fibroids are going to recruit vessels from other areas in the uterus, so your embolization is not going to work. So what you have to do in this case, in case of a fibroid or tumor, is you have to infarct the area that you're treating, and the only way to do that is to do it with particles. That's an important thing to understand about embolization, is that the level that you embolize is going to give you your therapeutic mechanism. So if you have, in this case, if you use particles, in the case of the pseudo, the particles are going to go everywhere and going to cause bowel infarcts. In this case, you want to be proximal because you want the collaterals to take over and perfuse the duodenum after you embolized it. Okay. And cases of tumors or benign tumors like a fibroid, you want to go really distal, so you cause infarction. All of that you'll learn that, and when you specialize more, like when is it important to go distal, when is it important to go proximal, and so forth. So this is an example of the angiogram pre and then post. We pruned all of these vessels. Somehow the uterus remains well perfused after embolization. Most of the particles go to the fibroid. This is a couple months afterwards. The fibroid shrinks and symptoms improve in about 90% of cases. So pelvic congestion is another application. This is when you have pelvic varices. This is a left ovarian vein venogram. You'll see that I'm injecting contrast up here in the renal vein. The ovarian vein comes in and joins the renal vein over here, and the renal vein is flowing towards the cava. But even though I did this injection, you see there's a ton of contrast going down the ovarian vein. This means that the ovarian vein is more incompetent than the Trump administration handling of the COVID crisis. It's completely incompetent. It's not holding on to any flow towards the renal vein. So the valves are incompetent. So what that causes is when a woman is standing up and walking around, gravity's pulling this blood in the pelvis and causing pain. So what we do in these cases, we sclerose these veins down here. I didn't show that because I don't have time, but on their way out, we coil these veins. We use pushable coils here, and then at the top, we can put little plugs to get really well controlled, and now we stop the reflux. Okay, it's a controversial treatment because it doesn't work in everybody, and the gynecologists think we're crazy for doing it. Postpartum hemorrhage is another one. This is a very tiny pseudoaneurysm in the uterus here. You can see on a sagittal MRI. This is the sacrum right there. This is the uterus and the bladder. There's this tiny little pseudo. We saw that on angiography. Went in there. We were able to glue it. I couldn't get my catheter past here, so this was a good application for glue because I couldn't get close enough to coil across this vessel. So another principle of embolization is that you don't want to just put the coil proximal to the pseudoaneurysm that you're treating. You want to go across it because the pseudo may recruit vessels from the other side. And if you blocked your front door, the back door may not be reachable. So you may be shooting yourself in the foot. So you have to get embolization across this lesion. Prostatic artery embo, you guys may have seen me do a couple of these. It's a really delicate procedure, technically really challenging. This is a cone beam CT during PAE, where we're enhancing half the prostate. This is an angiogram showing all the rich vascular supply. In these cases, you're using particle embolics, but you have to be super careful because the connections between these vessels are plentiful. And if you inject particles in some of these vessels, you may get particles going to the penis, to the bladder, and causing all sorts of mayhem. So you have to be really judicious when you're using these particles that you're only getting the target that you want. So oncologic embolization, I mean, this is a gargantuan field in and of itself. This is an example of an HCC being treated with lipiodol-TACE. So the chemotherapeutic drugs are mixed with the lipiodol stuff, and I told you it was really radiopaque, right? So that you can see it's really showing up on CT. This is a contrast, non-contrast enhanced CT. You see the lipiodol just lights up like bone. This is very dense. This is another application of embolization in the portal vein. This is in a patient that's going to get a hepatic resection, like a lobectomy. So because they don't have enough liver after the lobectomy, they want us to hypertrophy the liver so that they can be removed, they can remove the side of the liver that has the tumor, and they can still have a hepatic remnant that's enough for them to survive. So that takes a few weeks. So we embolize the portal vein, cause hypertrophy of the left side so they can chop off the right side. So it's an example of a colorectal metastasis treated with Y90 radioembolization, multiple lesions, responded really well to Y90. When we do Y90, we're handling this huge dose of radiations, beta radiation, and there's different kinds of radiation that we use. So beta radiation is when these atoms decay, they shoot out a little electron, and the electron penetrates several millimeters into the tissue, and that's the high energy electron that kills the tumor cells by disrupting the DNA. And we have to be really careful with this stuff because a lot of the radiation goes to the lung, and we have to be able to calculate how much of the radiation is going to the lung so we can keep track of the dose that the patient's getting. This is a case I did recently, a really sweet 83-year-old lady with a HCC. We did her angiogram. There's a tumor. It's in segment 3 in the liver. We administered the tech MAA here, calculated her shunt fraction. This is what it looks like. This is what the technetium MAA is, a dummy dose of radiation that we use. This is what it looks like on a PETS on a gamma camera fused with a CT. And then 3 months later, this is what on the arterial phase, what the tumor looks like. It's completely dead. So really good. This is a really good response. So questions, I know, sorry, I wanted to leave time for questions, but I didn't. So what do you guys have any questions?
Yeah, I've got a quick question. So obviously in like a non-trauma setting, would there ever be a time where you would want to measure, say, like the diameter of whatever vasculature you're trying to occlude before you, say, put out like a plug or something like that?
Yeah, so even in trauma settings, you still do that because you want to know the caliber of vessel that you're embolizing so you can select your device. So I mentioned the Embolics 4s. That device goes up to 8 millimeters. So if you have a splenic artery, for example, and it's 5 millimeters in diameter, the Embolics 8 would be fine. That's because you want to oversize those about 50%. So so you have to keep that in mind too. Yeah. So
and then
yeah.
Are those plugs retrievable too? So like
they are only at the time of deployment. So you can when you deploy them, they can be retrieved and repositioned. So if you deploy it and you're not happy with the position that they ended up in, you can pull them back before you deploy the device. They come. There's a tiny little screw in the plug, and when you spin the guide wire that plug's attached to, and that unscrews the little screw and allows you to deploy it. Taking them out after deployment is kind of a pain. You can do it right after you deploy them, but after a few days, they start getting incorporated into the vessel, and it becomes really hard to remove them. You can't really remove them after a couple weeks. They're just kind of in there for good because they're just stuck. They're just going to be incorporated into the vessel with organized clot, so that they basically get glued in place.
Cool. Thanks.
Yep.
I have a question for you, Dr. Uflacker.
Yeah.
So with uterine artery embolization, say it's like a young woman who has them and she wants to remain fertile, like comparing uterine artery embolization to like a myectomy or something more traditional, like how does that stack up with like conserving fertility for young women?
So one of the first things you need to ask a woman before you do a UAE is if she's done with family planning, because you will negatively impact her fertility because you're cutting off blood supply to much of the uterus. So the rate of spontaneous abortions in women that get UAEs is a lot higher. For women that want to preserve their fertility and they have submucosal fibroids, for example, myomectomy is a great choice because it will allow them, it will actually improve their fertility, and it won't, and it will also improve their symptoms. So, and sometimes we do those in combination, it depends a little bit. The UAE by itself is also another miniature universe. All of these things I talked about, we're just kind of scratching the surface. But we could go into a lot of detail into every one of these topics.